Hi guys, it's Jill. I'm going to talk today about the HESI exam. This review will probably help with your exit HESI. It should help with your CAT. It should also help with the management HESI. Again, we're going to review um, what I have. We do have a blueprint for the exit HESI, which Elisa has. This is the blueprint for the management, which I have, and we're going to go over in depth. I do not have a blueprint for the CAT, and I think we'd already discussed that at some other time. But I do believe that this information that I will be bringing to you, and the stuff that Elisa will be also lecturing you, is probably a good review for that also. So let's get started. There's a lot of fundamentals on this, which a lot of everything boils down to fundamentals. You realize that if you don't get that part, it's hard to get the rest of it. So we're going to start with that. This is a compilation too of both HESTs, and I apologize for that screeching noise that happens every so often. It's something with the fire detector, the thing. Just bear with me. Fundamentals, we'll start with number one that I've designated. It talks about delegation, client safety. For this, I think you can delegate safety to others, but what can you delegate? We have to remember what is tasks that can be delegated and who can they be delegated to. Regardless of any patient, whether it's home, whether it's nursing home, whether it's hospital based, wherever, there has to be a risk assessment tool that is in place that is used by that facility or that area. Even at home, there's still things that we do to prevent falls. So we would do a fall risk assessment at Grant. It is just a fall risk assessment. I know, like at Morgantown, it is Humpty Dumpty, I think is the one they use or have used in the past. So there's always that. There's also a Braden scale, which is assessing the skin integrity of a person to doing a skin assessment. But client safety for fall risk, what will we do? What would things that we would put in place for prevention? Some of those would be, and these are in no specific order, but those slippy socks that are placed on patients. The lights, which lights meaning that the room is well lit. Make sure the bathroom light works when it comes on. At night, sometimes they need that little night light to be able to see. Otherwise, that might be a hazard for them. Rails, anything other than 2 rails or possibly 3 rails, depending, is considered a restraint. So we would make sure, though, that they did have both side rails up. Those are also ways to help a patient pull themselves up in bed, be able to turn themselves, those things too. Make sure there's no throw rugs. This is more or less in the home, and that the pathway is free and clear. But even in the hospital, you have to have a clear pathway to at least some areas, to the bathroom, probably more or less to the hallway, to the door. We sometimes have a tendency to junk up rooms, especially with if the patient has a lot of equipment that's needed. O2 tubing, we'd want to make sure that if it's the long O2 tubing, that it is kept out of the way and they don't trip over it. And sometimes that's a hazard, and that's why they don't give them the long oxygen tubing. They'll just say, let's keep it to the short and not worry about it. Phone cords out of the way, excessive phone cords, we'd want to keep those out of the way so they wouldn't fall over them. We want to keep the remote close to the bedside if at all possible. At the hospital, some of the stuff's on the bed, like to turn the TV off and on, but they still need a remote to be able to turn the channels. So we would want to make sure that that was in place, because that's an important thing for patients when they can't get up and they can't move. It gives them some control over something, and they need to know that they can control something themselves. Make sure they have the phone at their bedside, whether it be the house line or you know, the line there at the hospital. If they have a cell phone, we want to make sure they have their cell phone close handy to them. They'd want to make sure they have a drink by their side. That may be water, whatever they like to sip on. Make sure their call light's in reach, and make sure they know how to use it. It's no good to give them a call light if they don't ever use it. I have found over the years a lot of patients don't want to turn the call light on because they think it's a disruption. It's not a disruption. It's what we're there for. You're supposed to use it. Some people would like to not give them the call light, or we'd like to take it away from them. And I've also been in that situation too. Assistive devices are in reach if they need them, if they need a cane, if they need their walker, if they need the bedside commode to be right there by their bedside, so they get up and they just get to the commode and they get back in bed. That's fine too, but we need to make sure that it's there, that it is emptied properly and cleaned. We also need to make sure for the male patients that the urinal's in place there at the bedside somewhere. Preferably not on the bedside table. That's kind of gross, but sometimes that's where it ends up, because that's where patients put it. Better place would be on the side rail, but if they can't get it off, it doesn't really, if they can't get the urinal off the side rail, it kind of defeats the purpose. So wherever they feel comfortable with it. Who's responsible for safety? Everyone involved is responsible for safety. We're all liable, no matter who we are. The only thing is, some of us have license and some do not. So who do you think it's going to fall to? The more responsibility is going to fall to the person that has a license, because that's the person that can be hit the hardest. So that is us. That is the nurse. That's me. That's you. As of right now, you may be a CNA. You may have a license. Yes, you may. And they can come after you too. But essentially, you have someone over you, which would be the nurse, which would be then a supervisor. There's a chain of command. And we need to make sure that we all answer call lights. We all check on safety. If there's a spill, sometimes you can't worry about housekeeping coming to clean it up. If it's something you can get yourself, for goodness sakes, get down and clean it up. Be done with it. Why would you call somebody else to do something that you can do yourself? If you need an alarm on, then we all need to be checking the alarm. This can be the bed alarm, this can be a chair alarm, whatever type of alarm system they're using in whatever facility. If it's not turned on, it's not going to do anyone any good. But if it is turned on, again, it's everyone's responsibility to make sure that it is answered properly and within a timely manner. Also, that it's turned on if it needs to be turned on. We need to ensure that we check that frequently. If someone needs frequent checks, it's not only the responsibility of the CNA or the UAP, it's a responsibility of everyone. It's a responsibility of all the nurses. Sometimes, even if that's not your patient, if that's not your side, if that's not your room, so what? You are a nurse. You are responsible to check on patients, whether they're yours or not. It's more of a courtesy, but you are obviously responsible for your own, but technically we're responsible for everybody, and we're a team. We need to remember that. So that's some of the things with delegation and client safety. Again, who is in charge of delegation? Who would we delegate task to? The safety things, a lot of that we can delegate to a UAP or a CNA. True, we can. we would be able to say, hey, I need you to make sure they have their socks on. I need you to make sure that the lights are properly turned on like they should be, that they have their call light in reach. But when you go in to do your assessment and you go in to check on your patient as you are charting that you are doing, it's also your responsibility to make sure that those safety measures are also in place. Second question, care of sepsis, POC, plan of care. What is sepsis? I'm not going to go over it. But how do people get septic? Think of the pathophys and the anatomy and stuff that has to go on behind this process. If we have a patient who comes in with a wound, a diabetic ulcer, for instance, what would be some things that we would make sure that were in place so that this person did not become septic? And I'm pausing to give you time to think on these things. But one thing we would do, we'd want to make sure that the wound is clean, the wound is dry, if at all possible. We want to make sure that someone would wash their hands and use proper equipment when they were touching or changing a dressing. How often would the dressings need changed? That would depend on what your physician would write for it. It also is depending on if the wound is draining and what kind of medication or dressing is placed on it. That will also determine how often it needs to be changed. With any type of dressing, you would need to make sure that you note the color, the amount, the size of the wound. If there is tunneling, usually we draw a picture, but now we do a wound camera, so they take a picture of it. It's placed in the chart or in the document, some scanned and put to the document so that we can track. This is what it looked like this week. This is what it looks like in 2 weeks. 2 weeks from that, hopefully we see healing. Hopefully we see changes that are for the good. If you have a person who has a catheter, or we want to make sure that we want to prevent UTIs. How do we prevent UTIs? Again, we take patients to the bathroom regularly. We make sure they're clean and dry. We make sure we wipe them from front to back. We make sure that, if they have to go or they're complaining, that we order what needs ordered. If they have a catheter, we're going to do catheter care. We're going to make sure that everything's clean. Try to make sure that the tubing doesn't get kinked and things get backed up where it shouldn't be. We want to make sure we wash our hands with everything. Make sure you use standard precautions with any task, whatever that may be. So if I'm writing a plan of care for someone who has sepsis, we would want to, again, use our standard precautions and our protective equipment, personal protective equipment, our PPE, as deemed necessary, whether this was a contact precaution, whether this was a airborne precaution, whatever precautions your patient was on. Regardless, though, we use standard precautions for everyone. If this person had an IV, what would we need to do with it? We would need to check to make sure that there was no signs and symptoms of infection or infiltration. They look different. Infection or phlebitis looks different than an infiltration. What is the difference between the two? If you don't remember, you need to go back and you do need to look at it. How can I tell what the difference is? How can I, what would I expect to be done for one versus the other? Are there differences or are there not? Obviously, with either one, we would take the catheter out, but most of your books will say you need to place another IV site in before you take the one out, so remember that. And you would document and do things per protocol and take action as needed. I think one of the things that we need to do within the hospital setting and whatever setting that we're using, we need to change our IV tubing per protocol and flag it. We need to say, hey, this needs changed every 3 days, and follow protocol. There's a reason why we do those things, because those IV tubings and things just hang there in a room, and that's at room temperature. What do you think's gonna? It's a good place for bacteria to grow and multiply. So we need to make sure that we do protocol with that. For finger sticks, we're going to follow protocol, and all of that. If you think of a person that has sepsis and think of plan of care, we also need to think of nursing interventions. What are interventions that nurses can do that we would expect to be done without an order, because it's a nursing intervention? Some of those nursing interventions that can be done without an order are what? Eyes and O's, daily weights, possibly finger sticks if it's warranted, vital signs. Vital signs are always in order, and with that, an O2 sat's in order too, to make sure that the patient is breathing as they need to. Ambulate the patient if there is no restrictions. Help them to the bathroom if there's no restrictions. Feeding a patient if there's no restrictions, or things of that nature. Administering medications, administering PRNs if you have those ordered as directed for certain things. Those would be nursing interventions that you could use. You could also do AM care. You can also, I had a thought, turn and reposition your patients in the bed. You can have the head of the bed elevated unless it is warranted that the head of the bed shouldn't be elevated. With a fresh hip or a knee, something like that, that may not be. Sometimes it's okay to use rice therapy on a patient. The rest, ice, elevate, and compression. Those are things that we would expect to be done because you are a nurse. You should know to do those types of things without being told. But again, if anything is warranted, that you don't do that. There are some instances where you're very careful. You don't do a lot of stuff sometimes with a hospitalized child. There's a little difference with that, and sometimes surgery patients, you really need to pay attention to what the doctor has ordered, because they don't always want certain things done because they want to know about everything. They want to be notified if there's any changes. Obviously, assessing for changes of level of consciousness or signs and symptoms of infection. Also for signs and symptoms of confusion. Change in level of consciousness. If we have a patient who is there for seizure precautions, what would we do? Probably pad the side rails. We would probably go ahead and have emergency like things for a crash cart at the bedside. We would remove things that would be harmful to the patient, remove remove clothing that's too tight, things like that. So those are some things that we could do. When you think about doing a plan of care, no matter for what patient, think of what's going on with your patient. What would I expect to be ordered? And then kind of go from there. As far as a sepsis patient's going to be very different than a patient who comes in to have pre-op surgery stuff. It's going to be different. But, we need to think of what's going on with your patient and have a plan of care accordingly. Next one, safety, notifying the HCP, which is healthcare provider. there are certain things that we can do as a nurse without, again, instituting, calling the doctor and things like that. Every time that you see notify the doctor, that's not always the right answer. Sometimes they want you to be able to think, use critical thinking, good judgment yourself. Then it may warrant that you call the doctor, but it may be that this is going to take care of it, so they would expect you to have done that before they called. If you have a patient who needs some restraints, obviously that is going to require a physician order. Physicians are the only one that can order restraints, and it does have to be documented um, within 24 hours. There's a lot of things that comes with restraints, and we'll talk about that a little bit later, but those are just some things that I thought maybe we should talk about. If you see your patient in the hospital may need some home health, we can kind of make a home health referral, but the doctor does need to be aware of it because essentially that's whose name is going to be attached to everything. Home health referral may just be for someone who requires a little bit of attention once they go home. They're not able to they're not going to be able to manage everything maybe for the first week or two, but once they get the hang of it, they'll probably be okay. Home health can be something that's longer than 2 weeks, obviously, too. So that's something that we can do. With that, you may need to involve social services, and they are a great tool, a great asset for anyone that needs home health because they know all the ins and outs about setting things up, who to call, who will be there, and they'll rearrange everything so there's not much for you to do because that's their job. May need to do a competency trial, may need to appoint a health surrogate for medical needs. Sometimes the patients come into your facility and I don't know why, but they don't leave the same as far as their mental capacity. It's almost like they come in and they have surgery and they're never the same again. It sets off that confused state that they've kind of put off, but now it's exacerbated and it's only going to get worse. So those types of people sometimes need a health surrogate or a medical power of attorney to make medical decisions for them because they're not able to do that themselves. And that will also have to be deemed that the doctor has to see the need for that. We can push forward, and again, we are advocates for our patients, for their safety, for the best care that we can give them, and if that requires doing this, then that's what we're going to do. So that's some things that you maybe would notify your healthcare provider for safety. Also, if something has changed, now they need these safety measures put in place where when they first came in they didn't, but they've had surgery now. That changes things. Or they have a UTI now. That definitely changes things. So we need to make sure that we are the advocate for the patient and we notify the healthcare provider if there needs to be more safety measures in place, and we can do that. Number 4, this one called for basic nursing skills, electrolytes, and vomiting. First of all, when we think about electrolytes and vomiting, there are lots of things that can be affected. I think with nursing interventions right off the bat, what would be some things that we would expect to be seen? We would definitely need eyes and O's. We'd need to weigh the patient if possible. Why would we want to weigh a patient? We need a baseline. They're probably going to be NPO at first, which may make the patient very upset. They don't understand why they can't have something to eat or drink. What is the purpose, and what would be the purpose of making the patient NPO? If you don't remember, you need to go back and look at these things. Then if they are once they are able to get something to eat, it's probably going to be light and clear liquids at first, and then we'll probably advance them as needed. What kind of medications would we expect to be seen for someone who comes in and they are um, electrolyte imbalance due to some excessive vomiting and diarrhea? What would be some things that we would expect to be seen? We would expect to have an IV site placed, maybe two. We probably wouldn't want small bore, but we would like as large as possible, at least a 20 if at all. But if we got a 22 and that's all we could get, that'd be fine till we got some fluids and got them hydrated. You also have to understand sometimes these people come in, they're severely dehydrated. You're doing good to get anything in, and what you can get is great. What kind of IV fluids would I expect to be hung on this patient? What kind of medicines would I expect to be used for vomiting? What kind of medicines would I expect to be used for excessive diarrhea? Think about the medicines that you would expect to be ordered. How would you expect them to be ordered? How would you expect them to be administered? If at all possible, if someone comes in and they're vomiting and diarrhea, do you think giving them something PO or per rectum is going to work? No, we need to do IVs. So we'd want to think about medications that can be given IV. Would we expect the person to have antibiotics? Not necessarily if it's not an infection that's causing this, but sometimes we won't know at first. So we would probably want to get lab work. And what lab work would we expect to be seen on this patient? A chemistry, which would show your electrolytes, obviously. We'd want a CBC. Why would we need a CBC? To see if there is an infection brewing, to see what's going on in the red blood cells and the white blood cells. What about your coags? Possibly would want that, because depending on what all the patient's got going on. The other thing is too, you have to remember that these patients come in, this is what's going on, but they have multiple comorbidities. You know, they have lots of things wrong with them to start with. This is just something that's right at the forefront. So we have to remember those things. What about your diabetics? Would we want an EKG? Would we want a chest x-ray? We might. Would we want a urine? Yes, probably so. We may need a stool sample. Also, remember too, once you get you would want to get your blood work before you started any antibiotics. And you would want to go ahead though and start your IVs and give your antiemetics and things like that, because that's not going to affect your white count or anything like that. So you could go ahead and do that. We would want to check their skin turgor. Think about people that come in and their electrolytes and they've been vomiting and diarrhea. Think about a child versus an adult. What's a lot of the differences that you're going to see? Again, who's vulnerable? The populations that are vulnerable are the very old and the very young. We would probably maybe want this person to be on telemetry. Why would we want them on telemetry? What can happen to this person if they've had a lot of electrolyte changes? How can we replace electrolytes? What are your electrolytes? your salt, your sodium, your salt, your chloride, your potassium. How do we get those? Lots of times through our diet. We can give chloride, sodium chloride. We can give potassium through our IV. We can give sodium. We can give this through IV stuff. We also, if you have a person that's at home or thinking they have some electrolyte imbalances, what are things that we tell people sometimes when they are, having a lot of vomiting and diarrhea? The sports drinks have a lot of your electrolyte replacements that you may or may not need. So you could definitely use that. Next, we have another question dealing with nursing process prioritization. I think for this question, too, you need to remember, what is the nursing process? What's the very first start? Assessment. When I think of nursing process, if you don't assess well, you really don't have to worry about the rest of it because it's not going to fall into place. But when we think about prioritization, also think about your ABCs in life and in what is most important. Again, we've talked about before, some of the fluffies are not important in a lot of instances. But when you're dealing with people that, as a suicide risk, that becomes number one over everything else. So you got to remember, what's your situation, what's going on with the patient, and then think about, what would be my first priority? What would I need to address first? That should be your number one thing that you're going to take care of first. And then we got to remember our nursing interventions. So again, what are things that we can fix as nurses without anyone kind of telling us to? What would we expect? The nursing process, again, of course, it starts with assessment. We're going to assess. We're going to assess vitals. We're going to assess maybe we're going to do I's and O's. We're going to do daily weights on this person, whomever it may be. We're going to possibly maybe assess their diet. What have they been eating? Is it stuff that fits the bill? We also need to sometimes assess what this patient knows about their condition. Maybe that has something to do with everything. If we have breathing, as the first priority, something with breathing, impaired oxygenation and all, how would we fix that? I would expect for you to obviously set the patient up. I would probably expect you to put some oxygen on them. I would expect that you would check their O2 sats frequently. With every patient, what would be the safe thing for the O2s? What would you put them on? Everyone's okay with O2 at 2 liters per nasal cannula until you find out more about the patient. Then you may up it, but until then, you probably wouldn't. And again, you got to think about, there's lots of assessment, because you keep going back to, you assess your patient a lot. If it doesn't work, then you have to evaluate what happened, what went wrong, assess and plan and implement again, because that didn't work. We also have to remember that each patient is different. We all don't fit the same mold. We're all unique. Care plans are a guide. Care plans are a blueprint for what we kind of can do and should do in certain instances, but again, not every patient follows that. They're all going to be very different. It's just something to guide you. We have to modify it and make it unique to each patient that we come in contact with. Again, there's another one for safety, priority client. How often do you chart? How often do you check on patients? That's going to be protocol for your facility, and it may be different. It's also going to be different depending on the acuity level of the patient. So, again, if you're working in an ICU or a step down unit, you're probably going to check on those patients a lot more frequently than you would on just a med surg floor. It's not to say that you don't check on your patients. That's not what I said. But the acuity is going to be very different. Some instances you don't ever leave the patient's side. You're a one-on-one, so you're always checking on them. You're checking on something. All you're going to get done is taking care of the patient and charting. So you want to know if there've been any changes, like if you saw a person being confused, that they weren't like that before. Now they become a priority. If you see a restless patient that nothing seems to help or work, they become a priority. Why? I've told you before, when someone is restless, if someone just can't get situated, can't get still, there's something going on. And it's really hard sometimes to know our patients because we've never seen them before, we've never taken care of them before, so we don't know if this is their normal or not. We can only go by the information that we're given. Sometimes that is their normal. Okay, that might be all right for this patient. But then again, what if it's not normal for them? And I haven't done what I'm supposed to do. Who's liable for that patient? You are. So we need to make sure that we check on them regularly, we chart on them regularly. If you see someone in pain, nothing that you've given has helped them, then you may need to call the doctor again and say, hey, I just don't know what else is going on. And when you do call the doctor, you need to have all your ducks in a row. This is my vitals right now. And sometimes it might just be something subtle, like if you've been checking their blood pressure every 15 minutes because they just can't seem to get situated. And you have seen a few subtle changes. You can't put your finger on it, but they're subtle. They're very subtle. You need to report that, but you also need to have documentation of it, that you were aware of it, you were documenting, you were trying to take care of this patient to the best of your abilities. Nothing was going on that you could visibly see at that moment, but you were checking on them, you were taking care of them, you were attending to them, you had not neglected them. You might need to just change their position. You might need to fix the lights. You might need to fix the heat or the air in the room. You may need to have somebody sit with them if possible. It might be you, if you have time, just to sit with them a little bit. Calm their fears. The thing about anxiety, it's a proven fact that if you tell the patient what's going on or talk with them about things, they are less anxious about things. Those are some things that we need to look about and think about. This is all for the first part of the fundamentals. I'll do another one and upload it. There are going to be several for the fundamentals. It's a big section, and then there'll be some critical care and some of the others. Please be watching too on your blackboard for the dates of the HESI. I do have to talk with Dr. Terrell to make sure that everything's okay with that. Also, make sure that you check Blackboard to see when assignments are due for my class, because I am going to go ahead and we are going to do the research project. You won't present, but you will put it on Blackboard. I do want you to do your mentor project. Some of you have already got that done, and it looks great, and I appreciate that. And we will look at that. If you look at the research project, it's worth 60 points according to your rubric in your syllabus, and I will put that rubric up if I think about it. I'll try to today. The rubric for your mentor project again is 60 points. I am going to take participation grades for you doing the practice questions, because I think that's a good thing for you guys. You do need to do practice questions, even if you are doing practice questions from another source or site. It's good to have practice questions from a lot of different venues. It gives you a different perspective on things. These are not graded, but they will be participation. There will be a timed exam, about 50 questions, I think it was. I've done it, I can't remember, but I haven't released it yet. And we will take it as a grade. It will be timed, so once you start it, you will have to finish it unless you run into problems, which you'll have to get back with me. I hope things are going well for you guys. I know this has been a transition and a trying time for everyone, but don't lose hope. We are going to graduate. You are going to take HESIs. You are going to take your NCLEX, graduate, and become nurses. There have been some questions about also waiving the number that is required for the HESIs. I'm not going to do that because you still have to take and pass an NCLEX. This is a good guide that lets us know if you're going to be able to do that or not. My advice to you is you need to study. You are not coming to class regularly. You don't have clinicals. I know you have assignments and all of that, but you should have ample time to prepare. And we are giving you these lectures to help with studying and things. So I really think that there's no reason why you can't get a 900 on all of them. And again, you have another chance if you don't. The CAT I'm not so much worried about because that's not graded anyway. It's just a recommendation of where you should be, but the other two are. And Elisa and I are, reviewing with you so that you will have something to go by. I expect you to, if it's in your best interest to listen to this lecture as many times as you need to, take notes, think back on things that you don't remember, go back and revisit those things. I will also be, as we get further along in this, there are some pages that I feel that are important that you look at. The NCLEX book is a valuable tool, very valuable. I looked at it several times myself while I was going through this for you guys to let you know that, hey, here's where it's at. This information is current and up to date. So let me know. Give me some feedback on this if you guys like this or you don't. I don't know how else to do it, but let me know, and I'll be either email me, you can text me. If you text me or email me, if I'm at home, sometimes I don't get it right away, but I will respond to you. So just let me know. Thanks. You guys have a wonderful weekend. Bye.